Niemann Picks Disease type C is a rare inherited lipid transport disorder that affects multiple organs, especially the brain. It is an autosomal recessive condition, meaning a child must inherit two mutated copies of either the NPC1 or NPC2 gene. These genes normally help cells move cholesterol and lipids out of the lysosome. When this system fails, lipids accumulate and cause widespread cellular dysfunction. NPC can appear at any age, from before birth to adulthood, and it is progressive and ultimately terminal. The genetics of NPC center around mutations in NPC1 and NPC2. NPC1, located on chromosome 14q24.3, spans more than 13 kilobases and contains 5 exons. NPC2, located on chromosome 18q11, is larger at over 47 kilobases with 25 exons. More than 486 mutations have been identified in these genes, including over 280 nonsense or frameshift variants. Some of the most common pathogenic mutations include ALA1035-VAL, PRO1007-ALA, and Phe221-SERFS20. Despite this range of genetic variation, most mutations disrupt the same essential pathway of intracellular cholesterol trafficking. To understand NPC, it is important to understand the normal cholesterol transport mechanism. Under healthy conditions, cholesterol enters the lysosome from the breakdown of lipoproteins. NPC2, a small soluble protein inside the lysosome, binds to cholesterol and transfers it to the N-terminal domain of NPC1, a membrane-embedded transporter. NPC1 then moves cholesterol through a specialized tunnel-like structure so it can exit the lysosome and reach its proper cellular destinations. When either NPC1 or NPC2 is defective, cholesterol becomes trapped inside lysosomes, leading to toxic buildup. The failure of cholesterol transport triggers a cascade of cellular and organ-level consequences. Lysosomes and late endosomes begin to swell with trapped lipids, impairing autophagy and damaging mitochondria. Disrupted lipid signaling impairs neuronal health, contributing to axonal damage and demyelination. In organs such as the liver and spleen, macrophages become foam cells, causing organ enlargement and chronic inflammation. In the brain, lipid accumulation leads to degeneration in multiple regions, including the cerebellum, basal ganglia, thalamus, brainstem, choroid plexus, and hippocampus. These changes contribute to progressive neurological decline. Symptoms of NPC vary widely depending on the age at onset. Prenatal and infantile presentations may include fetal ascites, enlarged liver and spleen, jaundice, hypotonia, lung disease, and failure to thrive. As children grow, neurological symptoms become more prominent. These can include developmental delay or regression, ataxia, clumsiness, seizures, dysphagia, speech difficulties, hearing loss, and downward or upward gaze abnormalities. A hallmark feature is vertical supranuclear gaze palsy, or VSGP, which impairs voluntary up and down eye movement. This symptom appears in about 65% of patients and is an important diagnostic clue. In adolescents and adults, NPC may present with cognitive decline, psychiatric symptoms such as hallucinations, or schizophrenia-like and bipolar-like features. Diagnosing and treating NPC is challenging, but research continues to advance the field. Blood biomarkers such as cholestain 3b, 5a, 6b trial, C trial, and 7-ketocholesterol are now widely used for screening. MRI imaging can reveal characteristic volume changes in structures such as the choroid plexus and thalamus. Treatment options remain limited, but include miglustat, which reduces glycosphingolipid accumulation, and hydroxypropyl cyclodextrin, HPVUCD, which enhances cholesterol clearance and reduces inflammation. Gene therapy approaches using AAV vectors are in development, offering potential future therapeutic avenues. While no cure currently exists, ongoing advances provide hope for improved diagnosis and care.